Welcome back to Long COVID Doctor, an educational series for all of you out there who are still suffering from long COVID. I'm Dr. Tim Robinson, formerly a family doctor, a GP for 30 years, now working in Long COVID Services for 5 years. I post on all the usual podcast channels and also on YouTube. I hope you find them helpful, and if you do, please subscribe, click away, let's spread the word. Just to say, there's no conflict of interest here. I do this for free. I'm not gaining anything financially from this. My reward is to help you out there to get better from your long COVID. So, thanks for all the feedback you send in, any comments, queries, etc. Apologize that I don't have the time to reply to those. I wish I did. I do read them though, and I do appreciate them because they help me with my future postings. So please keep them coming. Another apology, my usual disclaimer. It's important though, obviously. Any advice or treatment that I mention, please should only be considered after you've talked to your own GP or family doctor. So there we are. Let's get on with it. Okay. This is a podcast and post on melatonin and the use of melatonin in long COVID. So what's it all about? So basically, why should you be wanting to take melatonin for long COVID? Melatonin, we know it has sleep enhancing properties. People take it to help them to sleep. So fundamental question, sleep problems in long COVID. Obviously, I've done a podcast and YouTube post on this, sleep disturbance in long COVID. So what can we do about it? Well, a lot of patients are taking melatonin for it. Quick recap. Why is sleep disturbed in long COVID? Well, very briefly, basically, it could be due to the autonomic dysfunction, so dysautonomia, so excessive fight and flight response. It could be due to the inflammation that has occurred in the process of long COVID going on into long COVID. So the neuroinflammation, inflammation in the brain that affects the brainstem sleep center. Another reason for sleep disturbance in long COVID is the disruption of what we call the circadian rhythm, the day-night cycle. I'll come on to that in a minute. It could be due to hormonal dysregulation. Again, this is part of the dysautonomia, interference with the normal nerve pathways within the brain. So interfering with release of hormones from the endocrine glands, so a release of cortisol, but also a release of melatonin, the naturally produced melatonin. And then there could be the reasons, the physical reasons for disturbing sleep. So in long COVID, we know that obviously there's a whole span of symptoms, but you could have pain, for example, in your joints and your muscles, and then that can disturb your sleep. Breathlessness, likewise, with as a consequence of long COVID, can then also disturb your sleep. And finally, the whole process of having long COVID and not getting better, and the impact it has on your life in general, your interactions with your family, work-wise, financial, etc., obviously leads to mood disturbance and sort of anxiety and stress, etc. Those things can then lead to sleep disturbance. So long COVID and sleep disturbance, yes, it's a common thing. Many of our patients are troubled by that. They're telling us this when we see them in the clinics. So what are we going to do about it? Like I said, a lot of patients are looking for ways to improve their sleep. And one of the ways that they're doing that is by taking melatonin, buying it and taking melatonin tablets. So let's do a bit of background now. So what is melatonin? Basically, melatonin is a naturally produced hormone that we all produce in our brain, a particular organ or gland in the brain called the pineal gland. So basically, it's a hormone that is produced by the pineal gland, but at night only. The pineal gland is part of what we call the limbic system, part of the sort of the emotional regulation and also laying down a short-term memory part of the brain, the mammalian brain. The pineal gland is a tiny little gland. It's only the size of a grain of rice, but it sits there in the brain, and it's called pineal gland because it looks like a pine cone. Simple as that. Basically, it signals the body, melatonin signals the body when it's time to sleep. But it also acts as an anti-inflammatory and an immune regulator and an antioxidant. Basically, levels of melatonin, the naturally produced levels of melatonin produced by the pineal gland, are disturbed, reduced, and mistimed, if you like. It's released at the wrong time in long COVID. A little bit more on the mechanisms in its function. Like I said, it controls your circadian rhythm, your day-night cycle. Okay, basically the eye detects light and sends signals to something called the SCN, suprachiasmatic nucleus in the brain. It's very technical. And then signals from the SCN go to the pineal gland. Those signals switch off and on the pineal gland. Basically, in the light, the pineal gland is switched off. In the dark, the pineal gland is switched on. When it's switched on, it releases melatonin. Melatonin promotes sleep. It inhibits brain activity. That's what it does. So, its effects are it can reset the sleep-night, sleep-wake cycle, the day-night cycle, the circadian rhythm. It improves the onset of sleep. Like I said, it's a sleep enhancer. It improves the duration of your sleep. And it reduces the number of interruptions of sleep awakening, sort of waking in the middle of the night. It reduces the waking in the middle of the night tendency, and it improves your quality of sleep as a result of basically reducing those interrupted wakenings. That's its function with regard to sleep. Its function with regard to the immune system, basically it stimulates those white blood cells, the lymphocytes, the T lymphocytes, specifically the T killer cells, the CD8 cells, as well as the T helper, the CD4 cells. So it sort of actively enhances the immune response. It also stimulates a pro-inflammatory cytokine, so it brings about a release of that inflammatory mediator to dampen down a sort of an adverse effect from an infection. It also stimulates antibody production. So indirectly, it can therefore, because of those functions, it can indirectly dampen down that chronic low-grade inflammation in long COVID. That's what we want. It also has antioxidant effects. So basically, it is a scavenger for free radicals, reactive oxygen species. It is there to mop up those byproducts of metabolism, which those free radicals, reactive oxygen species, which are destructive to cells on many levels. And so it's a good thing that it's there in order to clean up those destructive byproducts. And it's interesting that melatonin levels are specifically higher in the mitochondrion, because remember, mitochondrion in each cell is what we call an organelle that produces the energy, produces your ATP. In that metabolic process, free radicals are thrown off as sort of garbage waste. And like I say, free radicals are very damaging. So therefore, melatonin's there, good news, to mop up those free radicals. So, I've told you the benefits, the effects of melatonin, like it improves sleep onset. It's a sleep promoter and quality. And the good news is that actually this is evidence-based. There are studies to prove this, to demonstrate this clearly, that it is very good at getting you to sleep quicker and sleeping more soundly. And there's some evidence, limited, that it reduces fatigue and brain fog. And there's some evidence that it basically improves the outcomes from COVID. Like I said, is some evidence that it improves fatigue and brain fog. My feeling is that, if your quality of sleep is better, then you're going to be more refreshed and you're going to therefore have less fatigue. But also, if you've had a restful quality 7 hours, 8 hours of sleep, it means you're going to be clearer thinking as well. So therefore, it probably does have a beneficial effect on fatigue and brain fog. Good news for long COVID sufferers, of course. So, what dose should we be going for? Well, basically, as in everything, start low, go slow. So start at the lowest dose, 0.5 milligrams to 1 milligram at night. And you can slowly increase it depending on and according to the response. You ideally want to take it, and it's common sense really, 1 to 2 hours before going to sleep. Sometimes higher doses are given than 0.5 to 1 milligram or even 5 milligrams, but only in the short term. So those are the doses. What formulations are there, and what types of pills? Well, there are 2 types of formulation, basically. There's the immediate release formulation, and there's the prolonged release. And so basically, prolonged or delayed, let's call it prolonged, but it is a sort of delayed release. It's sort of more of a gradual release. So immediate release is, as the word says, it happens, it releases very quickly, and therefore very good for those people who have difficulties getting to sleep, the insomniacs. So it enhances that, promotes that sleep, get to sleep quicker. Good news. For those people who wake in the middle of the night frequently, ideally you want a tablet that actually takes you right through. And so the prolonged release, delayed release formulations are more helpful for that group of patients. So basically it comes down to, what your sleep disturbance is and how it presents, like I said, if it's insomnia or interrupted sleep, that determines which of those formulations you choose. The formulations, these are synthetic melatonin, so chemically identical as the natural, identical to the natural, but it's not natural. It's not naturally sourced. Synthetic is obviously preferred because it's safer. You know what you're getting. There's consistent dosing. Really very important. So what about the safety? Again, this is evidence-based. What is the evidence-based? What are the studies, the clinical trials telling us? So basically, melatonin, synthetic melatonin that you can buy over the counter somewhere, I'll come on to that in a minute, is generally very well tolerated. Side effects are very rare, especially in short courses. What side effects are there? You should always know the side effects, potential side effects. Well, drowsiness. No surprises there because you're taking it to promote drowsiness, to promote sleep. So, that's going to have to be a side effect, of course. Another not uncommon side effect is vivid dreams because it increases your REM, your rapid eye movement sleep. Okay. So your dream sleep. So it's no surprise that you have vivid dreams. It's not uncommon, but it's not very common. Other, if you like, non-sleep related effects can be headaches. Some people report headaches. Some people report a form of nausea. So just to be on your lookout for those. Don't be surprised if you have those. They're rare, but that could be the reason. Obviously, common sense. If you do have side effects, then you're going to have to stop taking it or significantly reduce it, have a break, and start again at a reduced dose. Again, it's common sense. The good news is, again, this is evidence-based, that there's no evidence of dependency. You can't get hooked on it. Okay. You're not going to get withdrawal symptoms if you come off it. Unlike the sleeping tablets, hypnotics, temazepam, which very rarely used these days, but also the Z drugs, otherwise known as, which have taken the place of temazepam, and certainly diazepam as well. So the Z drugs, zopiclone, for example, and zolpidem, they can lead to dependence, but melatonin, there's no evidence, this is, based on trials, etc., that it leads to dependence. And hence, you're not going to get withdrawal syndrome when you come off it. There was a long-term study, 12-month study, with prolonged release, the delayed release formulation called circadin, and that was 3 milligrams. There were no adverse events, no withdrawal symptoms. So, like I said, it's evidence-based. Good news. Drug interactions, we should always ask and think about drug interactions when you're taking a pill, a tablet, especially if you're taking other tablets. So if you're taking SSRI antidepressants, so selective serotonin reuptake inhibitors, increase the 5-HT serotonin and address depression very effectively. Very clean drug. Now, the trouble is, serotonin and melatonin are derived from the same amino acid called tryptophan. Long story short, basically, microbiota, your gut flora, absorb and work on the tryptophan that you derive from your diet and absorb that and they work on it and they convert it into first 5-HT serotonin and secondly on into melatonin. So basically it's then absorbed into the circulation and concentrated around the body, specifically in the brain. So basically, if you're on an SSRI antidepressant, it increases your natural levels of melatonin, okay? And therefore, there's more of a sedative effect of the synthetic melatonin you may be taking for sleep. So basically, long story short, melatonin, if you're on an SSRI, such as sertraline or citalopram, then you will find that the melatonin dose you have may have to be reduced because it tops up the levels of melatonin, so you're more likely to be sedated, if you like. In a way, it's the same story for ladies who are on the oral contraceptive pill, or HRT. Again, natural, basically those hormonal preparations reduce natural melatonin production. Therefore, there's more sedating effect. Blood pressure pills, again, melatonin can interfere with blood pressure pills, but you've got to work with your doctor with this and obviously check the blood pressure on a regular basis. Sedatives, of course, again, sedatives, like I was just talking about sleeping tablets, there are some sedatives, some people who might be put on diazepam on a short-term basis for muscle spasm or short-term action for anxiety. Again, not used very much for that these days, but certainly diazepam for muscle spasm in back pain, say. They're going to have that has a sedating effect, and so melatonin also has a sedating effect. So the sedating effect would be worse, and so therefore, things like operating machinery and driving, etc. You'd have to be wary. Those are the drug interactions you should be aware of. Talk to your doctor. If you're on a drug, run it past the doctor. Say, is it okay, doc, if I take melatonin? Is there going to be a clash? Yes or no? Okay. Whilst we're on that, taking that into consideration, you've got to think of special populations, if you like. The elderly are going to be more sensitive, so use lower dose, common sense. Pregnancy and breastfeeding, there's limited safety data. So I'm, safety first, always. That's my go-to. Limited data. So therefore I say, actually, why take the risk? Don't have it when you are either breastfeeding, because it can be given to the baby, or in pregnancy, indeed. Theoretically, it can make autoimmune diseases a little bit worse, trigger off an inflammatory phase of an autoimmune disease, such as rheumatoid arthritis or Crohn's disease. So be wary. Also, liver disease, obviously, it's processed by the liver. So remember that, if you've got some liver impairment, that it's going to hang around for longer. How do you get it? Where do you get it? Okay, so basically here in the UK, low-dose prescription is possible, such as in its form, the prolonged release circadian. In the UK, in the USA, basically it's available across over the counter in pharmacies, etc. Certainly in Europe, it's available in pharmacies, and just walk in and buy it over the counter. But if you're doing that and or getting it online, even basically always beware of the quality and the dosing, because formulations can vary. Like I said, you can get it prescribed here in the UK, and but it's all to do with the license. What is the license? What does the drug license allow us to prescribe melatonin for our patients here in the UK? Well, basically, it's prescribable for 3 categories of patients. One is for insomnia, short term, in patients who are 55 and over. And for a maximum of 13 weeks, like 3 months. And that's the prolonged release, delayed release form, 3 milligrams circadian. Correct. 2 milligrams circadian. Sorry. Second indication would be for jet lag. That's immediate release. So 3 milligrams, 5-day max. And then long-term use in adults who have learning difficulties. That's the prolonged release form, but that would be initiated by a specialist. So you're probably asking the question, why is it only prescribable on the data sheet for people over 55? Well, I looked into this and found the paper upon which it was based. So basically a clinical trial was done on the use of melatonin in patients. Okay, let's just go back one step. What do we know? Natural melatonin falls with age. Okay. So therefore, in this study, they chose people who basically were slightly old, so 55 and above, because of that. So we knew that their levels were low, so therefore they were chosen to be in this study because of their lower levels. So it showed effectiveness. That study showed effectiveness and safety of prolonged release melatonin. So the prolonged release, say the circadian, the 2 milligrams, that if you like, slowly, if you like, is released through the night. So this group of patients were given it in either between 6 and 12 months, continuous treatment. And in those patients, at the end of that 6 or 12 months, there were no adverse effects, no withdrawal effects. Certainly, beg your pardon, at 12 months. That's really, really reassuring. Like I said, yes, there are some doctors, and I applaud and congratulate them, who feel, actually, I'm going to prescribe this off-label for patients with long COVID sleep disturbance. And we know it's safe, we know it's effective, and so I can't think of a reason why not. Okay, it's not expensive either. But like everything, it's a case of, doctor, patient talking it through, and for the patient knowing that it's off license, it's off label, off license, not, part of not on the data sheet for its prescription. So that shared decision making has to take place. How long to use it for? It can be used for short term or longer term. Some patients benefit from it, just using it every now and then, a short burst of it, intermittent use. I think that's great. But like I said, actually the studies support that you can use it for long term with no adverse effects. As always, you want the lowest dose possible, don't you? Because you don't want to run into the potential side effects that I outlined earlier, that excessive sleepiness in the daytime, but also those vivid dreams. Okay, that's coming to the end, What are the key takeaways in melatonin in long COVID? So basically, first and foremost, I think it's a low-risk option for those patients with sleep disturbance. There are not only it's going to improve your sleep disturbance, better night's sleep, like I said, theoretically, potentially, improve on your fatigue, improve on your brain fog, but also those other effects, those anti-inflammatory effects, those antioxidant effects. Obviously, it's a win-win. The evidence is strongest for sleep, improvement, duration and onset, but also there is evidence, but not as strong for those other, like I've said, fatigue and brain fog, but there is evidence. Like always, it's a case of individualizing the dose and monitoring the response. Basically, if it's not working, has no effect on your sleep, stop it. If it is, and it's improving, hence improving your symptoms and other symptoms, then there's no harm in continuing with it. Basically, you've got to work with your GP. So there it is. Melatonin treatment, synthetic melatonin treatment in long COVID. I hope you found that helpful. As I said, this is an educational series for you, long COVID sufferers, and if you have found it helpful, spread the word, the word with anyone else who has long COVID. But remember, like what I said, again, my usual disclaimer: any advice or treatments that I have recommended, and specifically here in melatonin, discuss it with your doctor first. Remember, safety first, always safety first. So as I said, thanks for any sort of feedback you send me. Keep it coming. It helps me with our future postings. And in the meantime, I hope you, are going to benefit from this series and, keep listening. I'm looking forward to the next posting. So in the meantime, I wish you well. Cheerio now. Goodbye.